Well, number one, it was an amazing choice for debate. I think at the end of the day, what we're trying to do as oncologists is we're trying to optimize long-term benefits and outcomes for our patients when they receive therapy. And what we're also trying to do is ensure that as high a percentage of patients as possible benefit from this durable therapeutic outcome. And what we've realized over the course of decades in non-small cell lung cancer is that it's going to take a combination of systemic therapies that are getting better and better, as well as local therapies in order to optimize that durability. And so, what I mean by that is systemic therapies have gotten better, whether they're TKIs for targetal mutations or immunotherapy for patients with a good PD-L1 status. Patients are doing better, they're living longer. But what we know for sure is that at some point in time in their treatments, the disease is going to come back, and there's going to be progression of disease. And usually, what we've identified, either in an older era of cytotoxic chemotherapy or in the more updated era of immunotherapy and targeted therapy, is that the cancers will come first and they will fail first in the original sites that they had gross disease. And so it makes a lot of sense for us to say, if we radiated those original sites of gross disease at the time of consolidation, that maybe those sites would no longer progress, and we would have a more durable period of time in which the patient's not progressing, and then eventually when they progress, maybe it will happen distantly. And so that, I think there's a significant amount of randomized phase 2 data to support that. Even though the LU002 trial, which was a randomized phase 2/3, that was a larger trial looking at that same question, closed early to enrollment because it didn't meet a pre-specified endpoint. There are probably still significant subsets of oligometastatic patients who would benefit from local therapy at consolidation. They probably would also benefit from local therapy at oligoprogression as well, as just a different point in time. But again, the ultimate role as oncologists is for us to define and determine what sequencing and what time points and what indications would allow us to optimize a durable treatment response. And I think that will only get done if you combine local and systemic therapies.